Hello friends, I welcome to all of you in medterminal.com. We are going to discuss about development of heart with quick reason and clinical pathology of embryology of heart. Before going in detail, please be friendly of some words which are frequently asked, and they are: heart develops from lateral plate mesoderm, that is actually splanchno pleuric mesoderm, around third week or 18th day from splanchno pleuric mesoderm, that is from cardiogenic area, and this cardiogenic area is situated at, if this is buccopharyngeal membrane and this is cloaca of mesoderm, then this cardiogenic area is situated cranial to buccopharyngeal membrane, cranial to buccopharyngeal membrane. This cardiogenic area forms two heart tubes. These two heart tubes fuse and form one heart tube. Initially, this one heart tube is forming at the cranial most part, and cranial to this cardiogenic area there is one coelom which is known as pericardial cavity. Pericardial cavity, and the cranial most is septum transversum. After head folding, these whole three structures, means chest tube with pericardial cavity and septum transversum, comes in chest cavity, and septum transversum forms diaphragm and fibrous pericardium and mesentery. And because of lateral folding, these two heart tubes form one heart tube initially, and posterior to this heart tube gut is situated. This gut is initially connected to this heart tube, and this is mesocardium. This fold of mesocardium is known as dorsal mesocardium. When this dorsal mesocardium degenerate, it forms transverse pericardial sinus. When this heart tube fuse, it goes in some serial dilatation and constrictions and form 5 parts. We are going to discuss in next slide, but right now please be friendly about lateral plate mesoderm, 18th day, cardiogenic area which is situated cranial to buccopharyngeal membrane, and lateral folding results in formation of one heart tube with posterior to which gut is situated and get attached to dorsal mesocardium. And because of head folding, this part, which is cranial most part, comes in chest cavity, and when one heart tube forms, after serial dilatation and constrictions, it forms 5 parts, and we are very aware that the lowermost part is sinus venosus, which is having two horns, right horn and left horn. Above sinus venosus, it drains blood into primitive atrium, from where blood is going into primitive ventricle, then bulbus cordis, and the uppermost part is truncus arteriosus. Cranial end is arterial end, while lower end is venous end. This is venous end, and blood is going initially from caudal to cranial direction. From truncus arteriosus, blood is going towards two dorsal aorta via pharyngeal arches and aortic sac, If you see very carefully, then uppermost part of tube is fixed through pharyngeal arches, and during head folding, septum transversum goes in chest cavity and forms diaphragm and fibrous pericardium. Hence, uppermost portion as well as lower portion is fixed. Hence, tube start dilatation and constrictions, and with further development, it will start folding upon itself. Initially, it forms S-shaped band, and later it forms a U-shaped band. Why U-shape? Because the lower portion goes posteriorly like a U, and not only posteriorly, but when it goes posterior, it goes superior also, like this. What happens with the future? Bulbous cordis comes to the rightward and rightward and downward direction, and primitive ventricle will shift to the left side of the tube. Hence, this is bulbous cordis and this is primitive ventricle. Here is truncus arteriosus. Now what happened with this lower pole? This lower pole, which is having primitive atrium with sinus venosus, it makes a U fold like this, U fold, and it goes posteriorly, and after going posteriorly it gets enlarged like this, and this upper portion, superior portion or upper portion, which is having primitive atrium, now starts projecting through truncus arteriosus like this. This will primitive atrium and it is projected through this truncus arteriosus, and here is our sinus venosus. Now what is the fate of these 5 parts? Fate of these 5 parts I have explained in detail in my previous lecture of heart embryology, but let's revise it fast. This sinus venosus, after absorption into right atrium, it will form a smooth part of right atrium, and this right horn anterior cardinal vein will form SVC, while right horn posterior cardinal vein will form with vitelline vein will form IVC and portal vein. What happens with left horn? This left horn will form coronary sinus. These all 3 openings during absorption of sinus venosus, they are looking into right atrium like this. This is SVC opening, and this is IVC opening, and this is coronary sinus opening. Same time, atrial septum starts developing. This is atrial septum developing towards endocardial cushions. The first septum which is appearing is known as septum primum, which is having 2 pores. The lower pore is foramen primum and the upper pore is foramen secundum. Then this primitive atrium will form both rough part of atria, means right atrial rough part as well as left atrial rough part. Now question is, from where left atrial smooth part arise? Left atrial smooth part arise. This left atrial smooth part arise through absorption of 4 pulmonary veins. Absorption of 4 pulmonary veins forms the smooth part of left atrium, while the smooth part of right atrium is formed through absorption of sinus venosus into right atrium. This primitive ventricle will form left ventricle, while this bulbous cordis, now look very carefully about this bulbous cordis. This bulbous cordis is having 3 parts. The lowermost part of bulbous cordis will form right ventricle, while the middle part will form outflow tract of both ventricles. On the right side, this will form infundibulum, means it will connect pulmonary trunk to right ventricle, while on left side it will form aortic vestibule. This aortic vestibule will connect left ventricle to aorta, and the distal most part form bulbar ridges. These bulbar ridges will take participation in formation of spiral septum along with conus and truncus, and this truncus arteriosus will divide into two parts, ascending aorta and pulmonary trunk, by forming spiral septum. And how this spiral septum is formed? This spiral septum is formed because of neural crest cells migration into truncus arteriosus. This truncus arteriosus is initially a tube, but when these neural crest cells migrate into this truncus arteriosus, it forms a spiral septum like this. An anterior part of this truncus arteriosus, there will be pulmonary trunk, and posterior part aorta will form. This is the fate of whole heart tube. Okay, I have explained about sinus venosus fate, primitive atrium, primitive ventricle, bulbus cordis and truncus arteriosus fate. Now again see what happened during the development of bulbus cordis. I have explained multiple times during my first lecture that bulbus cordis starts shifting toward rightward direction and downward direction. This movement occurs because of dynein protein, and because of this primitive ventricle starts shifting in the leftward side. Hence the mid part of tube take this configuration, and here is our truncus arteriosus. After this, the lowermost part, which is composed of primitive ventricle along with sinus venosus, they go posteriorly and superiorly, and after going posterior and superior, it starts elongation like this, and it starts projecting through truncus arteriosus like this. Okay, now this is important. This form a U-shaped band and S-shaped band because of this dynein protein. This dynein causes looping of heart. What I am saying? Looping of heart tube. This looping is known as dextrolooping. Dextrolooping of heart. Because of this dextrolooping, heart shifts into left side of chest cavity, which is normal phenomena. Please look here, this X-ray. If you see this heart shadow, it is comparatively towards the left side. This is lung shadow and these are ribs, but this opaque shadow is heart shadow, which is comparatively on the left side. This is left and this is right. This is because of dynein protein, and this is known as dextrolooping of heart. But if in some pathology, if there is absence of dynein or dynein protein is deformed, then delooping will not occur. Because of absent delooping, heart will shift into right side of chest cavity, which is known as dextrocardia. What is this? Dextrocardia or situs inversus. What is situs inversus? Situs inversus is because of dynein protein defect. Another syndrome which includes three pathologies. What are these three pathologies? It is because of ciliary movement defect. it was situs inversus was dynein protein defect, and this is Carthaginar is because of ciliary movement defect. It is actually autosomal recessive genetic disease or syndrome because of ciliary movement altered or defective. If there is ciliary movement of lungs is defective, then secretions will get accumulate in the lungs, hence multiple infection will occur, and which results in bronchiectasis. If this ciliary movement is defective at sinuses, it will result in sinus infection, so sinusitis will occur. And also patient is having situs inversus or dextrocardia. These three problems known as Carthaginar triad: bronchiectasis, sinusitis and situs inversus is Carthaginar triad. These maybe have infertility because of sperm dysmotility and fallopian tube immobility. Now I am introducing you about a new term that is known as cardiac laterality. What is the meaning of cardiac laterality? Cardiac laterality means it is morphological asymmetry. Morphological asymmetry. Why morphological asymmetry? If you look carefully about this X-ray, then you will find that on both sides mirror image is there, means clavicle is on both sides, right and left. These are ribs. If you see upper, then these are two eyes, these are two nostrils on both sides, two ears on both sides, two upper limbs on both sides and two lower limbs. But heart is comparatively shifted to the left side. This is the first organ which is showing morphological asymmetry during development. This morphological asymmetry is known as cardiac laterality. Why cardiac laterality occurs? Responsible genes for cardiac laterality are homeobox gene, especially PITX2 gene and FGF8 gene, and two chemical transmitters. One is serotonin or 5-hydroxytryptamine and another is MAO. These four two genes and two chemical mediators results in cardiac laterality in embryo. If a mother is taking any drug like serotonin inhibitors or MAO inhibitors, then baby born by this mother will have cardiac defects. So these drugs are teratogens. Okay. Now I have explained this is cardiac asymmetry or morphological asymmetry known as cardiac laterality. Dextrocardia is right-sided heart because of dynein protein defect. Carthaginar triad is situs inversus plus sinusitis and bronchiectasis. Ectopia cordis. What is meaning of ectopia cordis? Due to defective development of chest wall. This is actually chest wall is not properly developed, hence heart is exposed and can be seen from outside. This exposed heart is known as ectopia cordis. Ectopia cordis means exposed heart. Why cardiac looping occurs? Why heart tube form S-shaped and U-shaped fold? I have already explained. Because on the upper end it is fixed through pharyngeal arches, at lower end it is fixed by septum transversum, which will form future diaphragm, mesentery, liver or fibrous pericardium. Now this is new question which is very important. What is heart field and what is role of retinoic acid in heart embryology. First of all, please be very clear in concepts about heart field. There are two heart field. First is primary heart field, another is secondary heart field. Primary heart field form left ventricle, while secondary heart field will form especially outflow tract of both ventricle. Which will form outflow tract? We are aware that bulbous chordae is forming the outflow tract. Hence, bulbous chordae is also formed through secondary heart field, means right ventricle is formed through secondary heart field, and some portion of atria. Which portion? Caudal portion of atria is formed through secondary heart field. Okay friends, which part of heart is formed through secondary heart field? Outflow part, that is formed through bulbous chordae, and bulbous chordae is also making right ventricle, hence right ventricle is also formed through secondary heart field. Now what is the role of retinoic acid during heart development? Retinoic acid establishes what? Antero-posterior polarity. Antero-posterior polarity. What is the meaning of antero-posterior polarity? Antero-posterior polarity means it also decides inflow part or inflow track versus outflow track. Means venous end of heart tube versus arterial end of heart tube is determined through this retinoic acid, and it also determines the ventricular compact wall synthesis. If you are aware that compact ventricular wall, primary heart field walls forming left ventricular wall, and secondary heart field which was forming especially bulbous chordae and outflow tract, it was forming the right ventricular. Hence, ventricular wall along with inflow and outflow tract with antero-posterior polarity is determined through retinoic acid. You can see whole slide again for review purpose. Okay, primary heart field, secondary heart field, bulbous chordae and outflow tract, primary heart field left ventricle, retinoic acid antero-posterior polarity, inflow versus outflow, venous versus arterial and establishment, cardiac looping because of fixed cranial and caudal ends. Again repeating the same things, lateral plate mesoderm, angioblastic codes, two heart tube form single heart tube with these 5 dilatations. Now what is showing this diagram? Actually I want to explain a clear image in your mind about formation of atrial septum and formation of ventricular septum, because we are going to discuss about atrial septal defect and ventricular septal defect. Hence I am going to repeat about formation of septas again in a brief view. First of all, from the roof of atrium a septum starts developing at the first time, and this first time septum is known as septum primum. On the floor of this septum primum and endocardial cushion there is a gap remaining. This gap is known as foramen primum. After some time on the upper surface another gap starts developing, and this gap is now known as foramen secundum. After formation of foramen secundum, from the roof another septum starts developing, and when it crosses the lower margin of the foramen secundum it forms a foramen which is known as foramen ovale. This foramen ovale makes a oblique course of blood. Initially blood was going straight from right atria to left atria, but after forming of septum secundum, which is having foramen ovale, now blood has to pass through a oblique course, then this foramen secundum, and then finally it goes to the left atrium. Why blood is shifting from right atria to left atria? Right to left atria. Because as we are aware that right ventricle is connected to pulmonary trunk, and from pulmonary trunk blood is going to the lungs. But as fetus is not breathing, hence forward movement of right ventricle is not occurring. Hence right ventricular pressure is high, then right atrial pressure is high. Because of this increased right atrial pressure, blood starts shifting from right atria to left atria. What happens after birth we will discuss just now in the next slide. Now you are aware about this septum, that this is septum primum. Where is the upper portion of septum primum? This upper portion of septum primum degenerate after formation of this septum secundum. This is the septum secundum, and the lower portion of this septum secundum is thick and firm, which is known as crista dividend. This is in new books. Crista dividend is known as thick and firm lower edge of septum secundum, and the upper edge of septum primum, which is forming the lower boundary of foramen secundum, this portion is actually thin and mobile like this. Means if there is blood flow toward left side, this will move away. But after birth, please see this diagram. After birth, when lungs start breathing, oxygenation of blood occur. This oxygenated blood through pulmonary vein come to the left atrium, and when a high amount of blood is coming in left atrium, then left atrial pressure will increase. This increased left atrial pressure shift this upper edge of septum primum towards septum secundum. But as this septum secundum is thick and firm, this is thick and firm, hence it will get stick and approximated. It will get stick and approximated with septum secundum. Means septum primum get fused with septum secundum, and now it will form a complete septum just after birth, like this. Now this foramen ovale is termed as fossa ovalis. This fossa ovalis floor, two questions. Floor is formed by, or boundaries of fossa ovalis is formed by. Floor is formed, if you look very carefully about this, this is the floor of fossa ovalis. Hence floor is formed through septum primum, while these are the boundaries of fossa ovalis, which are formed through septum secundum. Okay. Now there are some defects in atrial septum development. Most common defect is ostium secundum defect. This ostium secundum defect, I am again repeating, is the most common ASD. Now question is where it is located and how it forms. Two question: how it forms. Located, it is generally located at fossa ovalis, but may also present at superior or posterior to fossa ovalis. If you look carefully about this diagram, then what is the reason of the ostium secundum formation. These are two regions of forming ostium secundum, ASD. If there is excessive resorption of septum primum, actually I have already explained, this septum primum upper border, this upper border will resorb, but if the upper edge of septum primum is also resorbed, or there is excessive resorption of septum primum, then our ostia foramen secundum opening will be comparatively more. Here is our foramen secundum. This foramen secundum opening is comparatively more, hence it is known as ostium secundum ASD. Second region may be if there is no formation of septum secundum, or septum secundum is not developed completely like this, then there is more foramen secundum, hence it is known as ostium secundum ASD. Another pathology in atrial septum is known as ostium primum ASD. This is because of endocardial cushion defect. Either defective endocardial cushion or septum primum is not touching endocardial cushion properly. Then foramen primum is defective actually, hence it is known as ostium primum ASD. As foramen primum, we are aware that foramen primum is located at which part? Foramen primum is located at the inferior part. Hence, where is ostium primum located? Ostium primum is located inferior to fossa ovalis. This ostium primum ASD is comparatively rare, but it is associated mainly with Down syndrome. Other association of this ASD are fetal alcohol syndrome, Illis-Van Creveld syndrome, Piare-Robin syndrome, Ehlers-Danlos syndrome. I am going to repeat, don't worry. Ehlers-Danlos, Piare-Robin, fetal alcohol syndrome, TAR syndrome, Holt-Oram syndrome. This is the most common question is asked on Holt-Oram syndrome. This is absent radius plus ASD. Okay, and the syndrome which is associated with ostium primum is Down syndrome. Okay, these two pathologies you are aware that ostium primum is because of if foramen primum is excessively formed. How foramen primum is excessively formed? If there is defect in endocardial cushion, or when foramen secundum is excessively formed. This foramen secundum can be excessively formed if either septum secundum is not formed, or there is excessive resorption of septum primum. Location is confirmed. This will be on inferior side mostly, and this will be on superior or posterior side, or at fossa ovalis. Another problem is patent foramen ovale. What is the meaning of patent foramen ovale? Patent foramen ovale is anatomically these two septas, septum primum upper edge, is not approximated or fused with septum secundum. It is actually a gap. A gap remains anatomically. I am saying anatomically, not functionally. A gap remains anatomically. From this gap, we can pass a probe like this. Hence, it is also known as probe patency test. This probe patency test is not confirmatory that shunt of blood is occurring, means there is no mixing even after PFO is present or propatency is present. Okay friends, now we are moving to another pathology. What happens if there is premature closure of foramen ovale at fetus? Usually this approximation occur after birth, but if this approximation of foramen primum with foramen secundum get occur in fetal life, then it will result in early closure, which because of this right atrial blood is not able to shift into the left atrium. Hence right atrial as well as right ventricular pressure will increase and there will be hypertrophy. As left atrial is getting less amount of blood, hence left atrial as well as left ventricular side atrophy will start. We have discussed about atrial septal defect. There are 4 defect possibilities. Now we are discussing atrial as well as ventricular defect because of defective endocardial cushion. One endocardial cushion defect was ostium primum ASD, but if there is a lot of endocardial defect is present, then atria is not developing. It may result in only 2-chambered heart or 3-chambered heart. 2-chambered heart is known as core bilocular, means only atria and bulboventricular cavity is present, one atria and one ventricle. Or it may cause 3 ventricles, 3 chambers like this and this. If there is 2 atria is present, then it is core trilocular biatrium. Biatrium means 2 atria are present. If there is heart having 3 chambers and out of these 3, 2 ventricular chambers are present, then it is known as core trilocular biventricular. Means 2 ventricles are present in 3-chambered heart. This is 3-chambered heart which is having 2 ventricles. How it is possible? If there is complete failure of septum primum or septum secundum to form, this may happen because of endocardial cushion defects. Now we are going to discuss about ventricular septum defects. Before discussing about ventricular septum defect, please let clear how ventricular septum forms in your mind. This is bulboventricular cavity, this is bulbus cordis and primitive ventricle. This bulbus cordis will form future right ventricle and this primitive ventricle will form left ventricle. What happens from the bulboventricular cavity? From bulboventricular ridge, a septum, crescent shaped septum starts developing from the floor of ventricular cavity, and this crescent shaped muscular septum is now known as interventricular septum. And it is muscular part, hence it is termed as muscular part of ventricular septum. Then from the uppermost part of bulbus cordis, mid part of bulbus cordis will form outflow division of both the ventricles by forming bulbar septum. On the right side it will form infundibulum which will connect right ventricle to pulmonary trunk anteriorly, while on the left side it will connect left ventricular aortic vestibule to aorta posteriorly. This happens because of bulbar septum. Still there is gap remaining after formation of bulbar septum and muscular part of ventricular septum. This gap is filled by the proliferation of membranous part of endocardial cushion. This is the endocardial cushion. They start proliferating in the gap and forms a complete ventricular septa, and this part of ventricular septum is known as membranous part. Most of the ventricular septal defects occur because of defective proliferation of this endocardial cushion. Hence 90% VSDs are membranous type, while only 10% develop because of this muscular part. Only 10% VSDs are occur because of this muscular part VSD, while mainly VSDs are developing because of membranous defects. Few important questions frequently asked. Most common congenital anomaly in heart is VSD. Most common congenital defect in VSD is membranous part. Most common congenital heart defect is VSD. Most common acyanotic heart disease is VSD. Most common congenital heart disease which is associated with infective endocarditis is VSD. Usually this VSD is acyanotic. Why acyanotic? Because left ventricular pressure is high, we are aware. This left ventricular oxygenated blood go to the right ventricle, no problem. If this oxygenated blood is going to right ventricle which is having deoxygenated blood, then there will be no cyanosis. But gradually with time what happens, because of this increased pulmonary flow, because of this increased pulmonary blood flow, gradually pulmonary hypertension starts developing. Because of this pulmonary hypertension, pulmonary arteriolar proliferation results in reversal of this blood flow. Because of this reversal, deoxygenated blood, right ventricular deoxygenated blood starts shifting into the left ventricular cavity, and from left ventricle we are aware it is connected to aorta, and now deoxygenated blood starts going to the body, hence cyanosis may develop, and this cyanosis is known as Eiser-Menger complex. Okay, I am repeating, VSD is most common congenital heart disease which is mainly acyanotic, but when pulmonary hypertension developed, it forms Eiser-Menger complex and may result in cyanosis. We have discussed about VSD. ASD is two types. ASD is two types mainly, primum and secondum. Secondum is most common. This secondum is mostly because of if foramen secundum is more. How foramen secundum is more? If septum secundum not developed, or excessive resorption of septum primum. How ostium primum type of ASD develop? Ostium primum is usually rare, seen in Down syndrome, and it is excessive foramen primum. How excessive foramen primum? Because of endocardial fusion defect. Now VSD, which is most common VSD? Most common VSD is membranous type, 90%, and least is muscular type. This membranous type is because of endocardial fusions. Now we are going to discuss about truncus arteriosus. First of all, please imagine where is truncus arteriosus. This is bulbus cordis which will form right ventricle, and this is primitive ventricle which will form left ventricle, and here is our truncus arteriosus. This truncus arteriosus will form two tubes, ascending aorta and pulmonary trunk, because it forms a septum which is known as conotruncal septum or aortopulmonary septum or spiral septum. This septum is also known as bulboconotruncal septum. Why bulboconotruncal septum? Because lowermost part of bulbar cordis form bulbar ridges, middle part will form conal ridge, and truncus arteriosus will form truncal ridge. These three ridges, after migration of neural crest cells, these neural crest cells start migrating into these ridges and they will form a spiral septum. What is specialty of this spiral septum? This spiral septum opens pulmonary trunk initially in the anterior side, and then it goes to the left side like this. Initially it is opening in anterior, then to the left, and then go posteriorly. While this aorta is initially posteriorly, then it comes to the right side and then anteriorly. Aorta is opening into left ventricle, while pulmonary trunk is opening into right ventricle. This happens because of spiral septum. If by any mean this spiral septum is not formed, then what will happen? If a spiral septum is not formed, this spiral septum not formed, then what will happen? This truncus arteriosus will not divide into two parts. Means this bulbous cord is right ventricle as well as left ventricle open in a common chamber, which is truncus arteriosus. Hence, it is known as persistent truncus arteriosus. Second possibility, spiral septum is straight. Spiral septum is straight. Then what will happen? It will result in TGA or parallel circulation. Parallel circulation. I will discuss about what is the meaning of parallel circulation. And if there is, this is truncus arteriosus, usually spiral septum is forming in the mid, which divides pulmonary trunk anteriorly and aorta posteriorly. But if somehow this spiral septum shifts anteriorly or migration of aortopulmonary septum anteriorly, then this pulmonary trunk will be narrow and this aorta will be widely open, and it is not opening into left ventricle, it will also open into right ventricular cavity. This pathology is known as TOF, tetralogy of Fallot. This is the normal presentation. Please look this diagram. This is normal presentation of blood from left ventricle. From this left ventricle, blood is going to aorta, initially posteriorly, then rightward, and then anteriorly, and it supplies to the whole body. Body forms, this is the body, left atria from left ventricle and aorta from body. This body take oxygen and mix CO2 and form deoxygenated blood. This deoxygenated blood go into right atrium, from where it go to the right ventricle. From right ventricle, this blood go to the pulmonary trunk. Here you can see deoxygenated blood is coming into right atrium, from here right ventricle. From right ventricle via pulmonary trunk, this blood is going to the lungs, and lungs oxygenate this blood and again put this oxygenated blood into left atrium here. This become a circle system. Okay, this become a circle system. Please look very carefully. From left atria blood is coming to left ventricle, from where it is going to aorta, and from aorta this is going to body. From body, deoxygenated blood initially comes in right atria, then right ventricle, then pulmonary trunk, and then finally to the lungs. This become a circle system. But in TGA, which it become a parallel circulation. I am going in next diagram about PTA and TGA. These are two important anomalies because of defective atrial septum development, aortopulmonary septum development. What happens in patent truncus arteriosus? I have already explained. This is bulbous cordis and this is primitive ventricle. They are opening through truncus arteriosus, and this truncus arteriosus divides into pulmonary trunk and aorta. If there is no migration of neural crest cells, then this aortopulmonary septum will not form. If this aortopulmonary septum is not formed, then there will be only a single tube. This single tube will not divide into two parts. Hence, mixing of blood will occur. This mixing of blood will result in cyanosis. As the bulbar portion of this aortopulmonary septum is defective, hence bulbar septum, we are aware that also take participation in the ventricular septum development. Hence, this persistent truncus arteriosus patients have VSD, and this VSD will also cause mixing of blood, and this patient will have cyanosis. You can see this truncus arteriosus. It is not divided because there is no migration of neural crest cells, hence spiral septum not formed. In another pathology which is known as transposition of great arteries, what happens? Transposition of great arteries, actually arotopulmonary septum forms, no doubt, but no spiraling occurs. Spiraling not occur. Hence this septum is straight, and because this is a straight septum, what it results, this straight septum results in right ventricle, which should open into pulmonary trunk, is not opening into pulmonary trunk, instead it is opening into aorta, while left ventricle, which is usually opening into aorta, is not opening into aorta, it is opening into pulmonary trunk. What happened? Please look here. These are two parallel circulation. Left atria is draining blood into left ventricle, no problem. Left ventricle, instead of putting blood into aorta, it is giving blood to lungs, and from lungs this blood is again going into left atrium. If you see here that lungs are oxygenating this blood and putting again into the left atria through pulmonary vein, this side is oxygenated blood. And what happens on the right side? If you see carefully, SVC, IVC will drain blood to the right atrium. From right atria, blood will go into right ventricle. From right ventricle, blood will go into body through aorta. Right ventricle, usually blood shifts into lungs via pulmonary trunk, but through aorta, deoxygenated blood is going to the body, and from body again it is going to right atrium. Hence this forms two circle system, one circle and another circle is this. These form two circle system, two parallel circle. This two circle phenomena is known as transposition of great arteries. This transposition of great arteries in X-ray, I am explaining few more. This is known as egg on side appearance on X-ray. Egg on side appearance. Look, this is parallel circulation. If you look this, then please see this hole is showing what? Deoxygenated blood, and this is showing oxygenated chamber. So this is known as transposition of great arteries because of arotopulmonary septum develops, but it is straight. Another pathology is known as TOF. What is this? This is tetralogy of Fallot. What happens during arotopulmonary septum development? It develops in the mid, spiraling done in the mid, and anteriorly it is pulmonary trunk and posteriorly is aorta. But if because of some reason this arotopulmonary septum shifts anteriorly, then what happens? This pulmonary trunk will narrow or stenosed, while this aorta will open into right ventricle as well as left ventricle. Look here, this pulmonary trunk is stenosed and this aorta is opening into two. Usually it is opening into left ventricle, no problem, but this aorta, because of this anterior migration of this septum, also opening into right ventricular cavity. This pathology is known as tetralogy of Fallot because of anterior migration of arotopulmonary septum or spiral septum. What first pathology? This is pulmonary trunk become narrow or pulmonary stenosis. This is the first pathology. Second will be overriding of aorta. What is the meaning of overriding of aorta? Aorta is not only opening into left ventricular cavity, it is also opening into right ventricular cavity. Hence, cyanosis can be seen because it is taking blood from right ventricular cavity. And VSD is also developed. And fourth pathology is right ventricular hypertrophy. Why right ventricular hypertrophy? As there is a narrow outflow tract and blood in right ventricular cavity comes from this VSD because of high left atrial pressure. This pathology is known as tetralogy of Fallot. If one more finding get added in this tetralogy, then it become pentology. TOF plus ASD is known as pentology of Fallot. And what is triology of Fallot? In triology of Fallot, ASD along with pulmonary stenosis with RVH is triology of Fallot. What is this AV canal defect or persistent AV canal? AV canal defect, all four chambers of heart may intercommunicate. Please check this triology of Fallot again through books. I'm not sure. Please read it from books as well. We are moving to the next pathology, that is AV canal defect or persistent AV canal. What is meaning of persistent AV canal? We have read that if there is defective endocardial cushion, then atrial septum as well as this ventricular septum will become defective and heart may be two-chambered, three-chambered, and two-chambered heart is known as core bilocular, three-chambered is known as core trilocular, biventriculary or core trilocular biatrium. If this septum shifts toward right side, then it will result in tricuspid atresia. One last syndrome which is known as tossing binge syndrome. This is named on two scientists named as Tossing and Binge. Two scientists, Tossing and Binge. Hence it is named as tossing binge syndrome. What is this tossing binge? This tossing binge is actually double outlet right ventricle. Means right ventricle is having two outlets, one aortic outlet and one pulmonary outlet. This right ventricular two outlet or double outlet right ventricles means aorta is arising from right ventricle. We are aware that aorta is arise from left ventricle, but in this tossing binge, aorta is arising from left ventricle, and this pulmonary trunk shifts comparatively in the left ventricle. This pulmonary trunk overrides both right and left ventricle, hence double outlet right ventricle. And this pulmonary trunk have subpulmonic VSD too. Combination of this problem is known as tossing binge syndrome. Now few questions. Heart tube is formed at 18th day or 3rd week. CSD are seen at 3rd to 8th week. Why in 3rd week? If some teratogen or some genetic defects occur, then heart tube will be defective. Up to 8th week, because up to 8th week septum, atrial septum as well as ventricular septum and valve development, along with what development is going on? Truncal arteriolar septum develops. Heart is fully developed at 3rd month. With syndrome having congenital heart disease having strongest family association, please mug it up, Holt-Oram syndrome. We are aware that heart develops from splanchnopleural mesoderm, lateral plate mesoderm, which is cranial to procaudal plate or buccopharyngeal membrane, and near it is septum transversum is present. Venous end of heart tube, which is caudal, is known as sinus venosus. Syndromes which are associated with ASD, these are Pierre-Robin, TAR, fetal alcohol, Ehlers-Danlos, Down syndrome, and Ellis-Van Creveld. Which is most common ASD? Most common ASD is ostium secundum type. which is seen in females mostly. Why ostium secundum? Means foramen secundum is more. How foramen secundum can be more? If septum primum degenerate more or septum secundum not formed, then ostium secundum ASD will be seen. When ostium primum ASD seen, ostium primum because of endocardial cushion defects. This is seen mainly in Down syndrome. Location wise, this ostium primum ASD is situated at fossa ovalis, while this ostium secundum ASD superior to fossa ovalis, and this ostium secundum ASD is located at fossa ovalis or sometimes posterior or superior. This was inferior. Ostium primum ASD is towards endocardial cushion, hence it is inferior. Sinus venosus receive blood from all except. We are aware that sinus venosus, this is the lowermost part which is having two horns. Each horn received three sets of vein. Middle is vitelline vein from yolk sac, then umbilical vein from placenta, and then from body anterior cardinal vein, posterior cardinal vein, common cardinal vein. We are also aware about fate of sinus venosus. This right horn will form anterior cardinal vein will form SVC, posterior cardinal vein with vitelline vein will form IVC, and this left horn will form coronary sinus. This sinus venosus will form a smooth part of right atrium, and rough part of right atrium developed through primitive atrium. Derivative of vitelline vein is, we have discussed, IVC. Septum secundum arises from primitive atrium. SVC develops from superior vena cava develops from, we have discussed, from right anterior cardinal vein. Closure of interventricular foramen with formation of membranous part occurs via it. This is discussion about interventricular septum. We are aware that this is bulbus cordis, this is primitive ventricle, and this is truncus arteriosus. First of all, membranous part develops through bulboventricular cavity. Then this bulbar septa gives bulbar ridge give bulbar septa. Then endocardial cushions start developing and forms membranous part. If VSDs are seen, mostly it is seen in membranous part and 10% seen in muscular part. Now answer, left and right bulbar ridges. These bulbar ridges fuse with the proliferation of this endocardial cushion, that is membranous part. All are true except bulbus cordis and truncus arteriosus form ascending aorta and pulmonary trunk by forming a spiral septum. Okay, a spiral septum formed. This truncus arteriosus will form pulmonary trunk anteriorly and aorta posteriorly by forming a spiral septum. A spiral septum forms when neural crest migrate into truncus arteriosus. This is okay. This truncus arteriosus formed a spiral septum by the migration of this neural crest cells, and we have discussed that if neural crest cells don't migrate, then it will form persistent truncus arteriosus, or if they migrate but instead of making a spiral septum, if they make a straight septum, then it will form transposition of great arteries, means parallel circulation. And if aortopulmonary septum migrates anteriorly comparatively, then TOF will occur. Because of this pulmonary stenosis overriding of aorta with RVH and VSD. Now the another line. Inferior border of septum secundum is known as crista dividens. This is right. Inferior border of, this is new term, crista dividens. A smooth part of right atrium is developed from, for pulmonary vein, no. Right atrium smooth part is developed after absorption of sinus venosus into posterior wall of right atrium. These four pulmonary veins, after absorption into left atrial wall, they will form a smooth part of left atria. Okay friends, here we have completed whole development of heart with its clinical pathology, including atrial septal defect, ventricular septal defect, and spiral septum defects, and one more special pathology, that is Torsing-Binz syndrome, also known as double outlet right ventricular syndrome with subpulmonic VSD. Thank you so much for your patience listening. Please like, comment and subscribe. Thank you.